Okay, so I'm going to go ahead and start recording. If you have any questions, please put that in the chat throughout. There are a lot of us on this call tonight, so I will try to answer them. If I do not get to your question right away, I will try to get to it at the end. But I'm going to go ahead and start sharing my screen. Share. Thumbs up if you can see this. This is what we are going to be going over today. I see thumbs up. If you're not able to see or hear me, people always have issues with this. I suggest going out of the Zoom and coming back in. Sometimes it's just a technical thing when we do this. Awesome. I see a lot of thumbs up. So I want to show you something before we get started, and I will put it in the chat again. Many people always ask me, can you make a study plan for me? I could make a study plan for you, but that's not going to be helpful because, let me put the study plan here. Everyone is different. I don't know how much time in a day you have. There are many different factors. People study at different times. So I'm sharing this as an example. This is just an example of a study group that, a study plan that one of our group members was so kind enough to share with us. As you can see, they have week by week what they're going to do in the APGAR book and what videos of mine they're going to do. They even put in breaks. So on Friday, she's taking a break. Wednesday, she's taking a break. Going through the different modules on the exam and filling in a calendar. Notice there's a practice test here. This is a super organized way for you to be able to structure your studying. I would say if you have not written out a study plan, you need to do that, because you're going to feel very scattered if you don't have some sort of plan. So I'm not going to go through exactly everything here, but I just thought that this might be helpful for some of you to see for visual learners. Basically, she did 1 or 2 different lessons a day. Some of you might be able to do more. Notice the practice tests are also scheduled in here, and she backwards planned from test day. And there's some really important tips. 90 to 20 minutes at a time. So it's not like sitting down, cramming. As you know, if you've gone through my course, I always suggest sitting down in small chunks of time. Also, if you're not mentally in a space to study on a day you're supposed to, that's okay, right? We're humans. So if you're just not feeling it, like that's okay. Go to your schedule, change it up as you need to, do what's going to work best for you. So that if you are looking for the link to this, she gave me permission to share this in our study group. This is going to be a very structured way to make sure that you are hitting all of the points that you need to and getting through all of the material. I would say do not copy this, right? Everyone's different. This person studied over 7 weeks. Maybe you're studying over 10 weeks. Maybe you're studying over 5 weeks. Maybe you're giving different amounts of time to it. So I definitely suggest that you check it out, but do not copy it. I mean, you can copy it, but that is not really going to help you. So tailor it to your needs. Okay, let's go ahead and jump right into our study group today. So we are going to be doing test questions. We are going to be utilizing the chat function. What we're going to be doing is I'm going to be highlighting on the screen here. Very good news for those of you taking the test in the new year. You can now highlight and strike out on your ASWB exams. So where I highlight, you will be able to do that on your exam. So the way that I break down in my videos, it's going to be much more applicable to the software that you're seeing on test day. And for our visual learners and for people that really benefit, I've heard really positive things about people testing in the new year and utilizing those new features. So I think that's really a step in the right direction, especially for visual learners. So we're going to go through 10 questions today. Remember, I always say, if questions do not have rationales, they're not good questions. You will always see at the end of any of my questions, they always have rationales. Rationales help you understand. Rationales help you understand why you got a question right or why you got a question wrong. So we're going to go through these today. I might stop and ask you some questions. Some are going to be recalls, some are going to be applications, some are going to be reasoning. Great if you get them right, but what's most important is that you are learning strategy. You could know the content in a book backwards and forwards, but if you don't have a strategy for breaking down the questions, you're going to really struggle on this exam. It is a reading comprehension test. I will keep saying that it is a reading comprehension test. So we will go ahead and jump in. I will read the question. And when you are giving an answer choice, don't just put A, B, C, or D. That's great, but I want to know why you chose the answer that you did. So we will talk about some of these are going to be either you know it or you don't. But this is really a chance for you to get your thinking process out there and for us to go through questions together. So I will share also that study plan again at the end because our chat's going to get really full with a lot of things. And I will, with permission from the person that made it, I will also send it out. So don't worry if you didn't get to see that study plan. I will link it somewhere in for everyone to access. Okay. We're just going to start going through questions because I want to make sure that we have time to go through all of them. So number 1, which of the following is true about physical contact of a client by a social worker? So very straightforward question. We are looking for the one that is true or correct. So only one of these is going to be correct. So I'm going to highlight which is true about physical contact between a client and a social worker. Before we even look at the answer choices, what's coming to your mind? There's something that's definitely should be sticking out to you. Physical contact. This comes directly from something. Go ahead in the chat. Code of ethics. Code of ethics, code of ethics, code of ethics. There is a whole entire section on physical contact. Okay. Which of the following is true? A, physical contact is prohibited in all cases with a client. B, it is allowed to occur as long as the client's informed consent is obtained. C, physical contact and its use are at the discretion of the clinician. D, it is not allowed if there is a possibility of psychological harm to a client or it is sexual in nature. Which of the following is true? Only one is true for test purposes. And why? Why did you choose the answer that you did? I'll make it a little bit bigger for you all. Which of the following is true and why? This is a tricky one. Which of the following is true? And I will kind of pose some questions to you all throughout as we go. Okay, let's start eliminating. So let's see here. Physical contact is prohibited in all cases with a client. There were quite a few of you that selected answer choice A. However, A is not correct. There are some cases where we would have physical contact with a client. What are those cases? Go ahead in the chat. When would we touch engage in physical contact with a client? A handshake. You might shake hands with a client when they walk in, right? That's physical contact. You might be working in a school. I get lots of hugs from kids at school, right? I'm not going to say physical contact, this hug is prohibited. It's dependent. We want to stay away from answers that are extreme. We want to stay away from answers that are extreme. Prohibited in all cases, that is not accurate, right? So we know A is out. It's not prohibited in all cases. It's not prohibited in all cases. Let's see what else. Answer choice B. Yes, someone said fist bumps, right? If you're in a school, you might fist bump. You might get a high five. That is physical contact. That would not be prohibited. It has to be appropriate. B, it is allowed to occur as long as the client's informed consent is obtained. That is not true, because what would happen if the client said, sure, you can touch me? What's problematic about that? What's problematic if we just said, well, the client gave consent? There's power dynamics, absolutely. It's not appropriate to just let the client give informed consent. It may be sexual in nature. Even if a client consents and it's not appropriate, it's still not allowed. It's still not ethical. So just because a client consents does not mean that by the code of ethics, we should still engage in that. There could be sending many mixed, wrong, inappropriate signals. So it's not allowed to occur just if we get informed consent, because there may be some instances that are inappropriate to engage in physical contact. Physical contact and its use are at the discretion of the clinician. That seems like a decent answer, but is it our best answer choice? No, because D is a better answer. C is not necessarily a bad answer, it's just not the best answer. So sometimes I will say with this exam, you might get answer choices that you're like, this could be correct, but which one is the most compelling? So here we're thinking of code of ethics. The correct answer here is D. It is not allowed if there is a possibility of psychological harm to a client or it is sexual in nature. D is the correct answer. This is actually exact language out of the code of ethics. We never engage in physical contact if it's going to cause harm or if it's sexual. Any questions about this one? Even, I always do process of elimination. Remember, go through, why is a question right or wrong? Some of these were not necessarily wrong answers, they just weren't the best answer. When you have code of ethics ones, you want to make sure that it is protecting the client and protecting the clinician. Always remember that. Okay. Any questions on number 1? Okay. Number 2. A case manager in a senior center is working with a new 82-year-old female client. The client has been attending programming at the center for over 6 months. The daughter of the client calls the center and asks if she can attend one of the social events with her mother. The social worker informs the client and the client becomes physically distressed. She states, "I hate my daughter. She is horrible to me." How should the social worker respond? I am just going to have you read this on your own before we even start answering, because this is a lengthy STEM. There's a lot of reading and a lot of comprehension with this one. This is a question when I give you those tips. This is one I would suggest you going over a second time so you don't miss anything. There's lots of details. Okay. Who is our client here? Who is our client? 82-year-old female, so an elderly client. Remember, age matters. They always give you age for a reason. You have known this person for about 6 months. That's duration. Her daughter calls and says she wants to attend an event. So the daughter is calling and saying, "I want to attend the event." The social worker tells the client becomes physically distressed. So this is causing a response in the client. She says, "I hate my daughter. She's horrible," causing some sort of reaction. How should the social worker respond? 82-year-old client, you've been working with, daughter calls and says, "I want to come to the center." And the mom says, "I hate her. She's horrible to me." What do we do? Go ahead, put your answer in the chat and why. I will read the answer choices. A, call the daughter and inquire about the mom's cognitive functioning. B, inform the daughter she needs to leave as she is not welcomed by the mother. C, explore with the client why she has made this comment about her daughter. Or D, report the situation to Adult Protective Services. How do we respond? It's the best answer. And why? Let's start eliminating here. You always want to eliminate. Would calling the daughter and asking about the mom's cognitive functioning be breaking confidentiality? Yes, I see a lot of heads shaking yes. We are not going to call and ask about cognitive functioning. There's nothing in the question stem that assumes cognitive functioning is an issue. That would be inappropriate. This breaks confidentiality. A is a no-no. Do we need to tell the daughter she can't come as she's not welcomed. Are we there yet? We don't know why she's not welcomed yet. We might get to that point because maybe the mom doesn't want her there, but we don't have enough information yet. This is very reactionary without collecting information. So B is out. Do we have enough information to report? Do we have enough reasonable suspicion to report to Adult Protective Services at this time? No, I see a lot of head shaking no. No, we don't have any suggestion other than she says she's horrible to me. That can mean a variety of things, right? Maybe they just had a disagreement. We don't have enough information to report at this time. By process of elimination, that leads us with C. Explore with the client why she has made this comment about her daughter. You always want to gather more information before intervening. I would ask this client, tell me more what you mean about saying, when you say you hate your daughter and she's horrible to you, what do you mean by that? Did something happen? You know, like what is your history? There could be a very volatile history there. So for this one, process of elimination, how should we respond? We need more information. More information is needed. Don't ever proceed until you have enough information. Any questions about number 2? No. Okay, that one was pretty straightforward. We had a lot of overwhelming support for C. Okay, number 3, I'm going to put on the next page so we can have all the answer choices there. Okay, number 3. You are seeing a client who has been referred for clinical services by her primary care physician. The referral states the client has had headaches, muscle weakness, and disrupted sleep. The referral states the client is experiencing PTSD symptoms, but does not give any more details. During the intake session, it is most important for the clinician to focus on, before we answer, in this question stem, go ahead in the chat. What are important clues? What are important clues? What do you take from this? This is a referral. Referral comes up several times here. This is a client that has already, when we get referrals, it means they've probably made contact with someone else. So this is a referral and from a doctor, primary care physician. If you get a referral from a primary care physician, what's coming to your mind? Symptomology, yes, medical. It is also suggesting that they've been seen by a medical professional, correct, right? Like a primary care doctor would not just give you a referral without seeing the client because they're giving you medical clinical information. So they've been referred by their primary care physician. What are the symptoms? Headaches, muscle weakness, and disrupted sleep. All symptoms of PTSD, which is the diagnosis. And what do we know about PTSD? Trauma informed. We need to be trauma informed. We need to be sensitive. So that's a thing that we need to consider. This client has had trauma. They have a PTSD diagnosis. During the intake session, how long have we known this client? Not very long. Not very long at all. So knowing that we have a client coming to see us with PTSD, it is most important. If you get a question that says most or best, some of the answers may be correct, but given the question stem clues that we have, what is the most important thing for the clinician to do, to focus on? What the trauma was that prompted the PTSD diagnosis. B, the severity of the health symptoms and the need for medical intervention. C, active listening and rapport building with the client. D, structured questions to collect demographic information, including the client's presenting problem. Knowing the symptomology and the information that we have, what is most important to focus on here and why? What is most important to focus on here and why? See a lot of people saying trust, rapport. Very, very, very important to be trauma informed, right? I'll give you all a few more seconds and we'll start eliminating. especially knowing this is an intake, right? An intake, we definitely need to make the client feel comfortable. Let's start eliminating. Do you think that it's important to know the trauma in an intake session is the most important thing to focus on right away in the intake? We know there's a PT diagnosis. Do we need to dive right into the trauma narrative right at this point? Would that be appropriate? Would that be trauma informed? No. Some people might be willing to share that, but coming from a trauma informed approach, knowing that it might be very difficult or triggering for someone to talk about these things. So that's not going to be the most important thing to focus on in an intake session. Does the severity of the health symptoms and need for medical information apply here? And if not, why not? Why does that not apply to this question specifically? Because they've been referred by the primary care physician. Very, very, very good. Medical has been ruled out or has been evaluated. Someone said, been there, done that, right? Primary care says, here, they're coming to you. It would not do you much good to go back to the primary care. They would say, that's why I referred them to you, right? So that would just add more complications. So B is out. Structured questions to collect demographic info, including the client's presenting problem. That could be, but is that the most important thing to focus on with a client that has a PT diagnosis and you're doing an intake? Not when you do not have a supportive relationship to build off of first. We need to meet the client where they're at. We're engaging the client, right? This would be the assessment phase. Think of the helping process. We're not there yet. And they might feel more comfortable answering questions after we have built some rapport, especially when we are dealing with clients that might have a trauma past, which we know here. So the correct answer here is C, active listening and rapport building with the client. This is a trauma question, knowing how to be trauma informed, knowing to meet the client where they're at. But notice if you went through really quickly, you might want to do that answer choice B. And they have medical symptoms, but we got to go back. They've already been checked out. They've already been cleared by the doctor. So make sure you're reading really slowly, because if you missed that detail, you might have been led to the wrong answer. Any questions about number 3? Active listening, very important. Meeting the client where they're at, letting them know it's a safe space, letting them know they can share as much or as little as they would like. Okay, someone was saying they don't have sound. If you don't have sound, you got to exit out and come back in. It's probably a Zoom glitch. So no worries. I will let you back in if you need to jump out and jump back in. Okay, number 4. In the first session with a school social worker, a high school student reveals he frequently skips classes and drinks during the school day. He said his mother is not aware of his behavior and he often produces fake sick notes to account for his absences. What should the social worker do first to support this student? Go ahead, read this one on your own. There's a lot of those 5 W's here. Who, what, where, when, why. We're in a school, so our role is a school social worker. High school student, we don't know age, but we know typically high school students are anywhere between maybe 13 and 18. So we know we're dealing with adolescents here. We're not dealing with young children. Presenting problem, he skips classes and drinks during the day. He comes to us and says, I skip and I'm drinking during the day. His mother is not aware of this behavior, and he's producing fake sick notes so that he can skip. What should we do first to support this student? Go ahead. What should we do first and why? What should we do first and why? Knowing who our client is. Thinking of the helping stages, thinking about the presenting problem. What's going on here? Give you maybe 30 more seconds, and then we're going to start eliminating and talking about why some are correct and why some are need to be eliminated. Let's start off the bat. What is problematic about B? B should be ruled out right away. Speak with the student's teacher to obtain collateral information regarding his behavior and attendance record. What's problematic about that is a first step. Why would we not do that first? Confidentiality, right? Is the student going to trust you right off the bat if you go to his teacher and get information? As a teenager, no. Breaks confidentiality. So B is out. B is out. Do we have to inform the, do we have to tell the student it's our responsibility to inform his mother about his behavior as a first step? Why or why not? Remember, this is a first question, so we need to have a starting point. We might need to tell the mother at some point, but is that the first step? Not at this time. Not at this time. What do I always tell any underage client? What do I say? I tell them about when I would have to break confidentiality. What you say here stays here unless you are a danger to yourself or you are a danger to others, right? So the client should know that up front, but that needs to be a conversation. It needs to be rapport building first. Do we report this case to CPS? Why or why not? Underage drinking happens. CPS is not going to take a call for this unless the client is a danger to themselves or others. This is not a concern on the part of the parents neglecting the child. So if I've worked in a school, if there was in high schools where every underage drinking occurred, CPS would have nothing but calls for that. You have to think of what's appropriate developmentally, right? There are things that go on, there's peer pressure. I'd want to know how to keep this client safe first and why there's underage drinking going on as well, right? It does not say that he had to get his stomach pumped or needed medical attention. There's no clues to indicate that yet. We don't know what underage drinking means. Does it mean he tried it once? Does it mean he engages it in it every day? We don't know yet. So this is out. We would not call CPS first. Process of elimination, what do we do first? Explore the reasons for the student skipping classes and the factors contributing to the behavior. I want to know more information. Why are you skipping classes and why are you producing sick notes? What are some reasons why the client might be skipping and producing sick notes? Just hypothetically. He might have a peer pressure. Maybe all of his friends are skipping school, right? Maybe they're like, let's all leave after lunchtime and just go home and go hang out at my house. Maybe school is hard for the student. Maybe the student is engaging in avoidance of being in the classroom. Maybe they're having challenging peer relationships. Maybe the schoolwork is hard. Maybe there's other stressors. There could be so many reasons what is going on. Maybe there is mental health stuff that we need to draw attention to, right? Maybe there is violence going on in the community. Maybe there is domestic violence in the home. There could be so many reasons that we don't know yet. We cannot make any assessment. We need to explore, right? We need to explore what is going on and why he's engaging with this behavior. Any questions about this one? Okay. Let me put number 5 down here. I'm going to make this bigger. There we go. On the new software as well, you will be able to make the font bigger or smaller. So someone asked, why would we not address his drinking first? We need to first build rapport, but none of these answer choices other than D are the first step that we would support him in. Right? We're here as the school social worker to support the student. I would want to collect more information about the drinking and the severity, but that's not the first step. Any questions about that one? That's a tricky one. I might need to inform his mother, right, at some point, but not the first step. I need to know what's going on first. I need to know the severity. I need to know how often. I just don't have enough information yet to do anything other than explore. Right. Someone said if he says his parents are serving him alcohol, that's a much different situation, right? Or if they know this is going on and they're allowing the behavior, there's a variety of different things. We don't make assumptions. We go with the information that we have in the question stem. Best thing is to get more information at this point. Okay. Number 5, what is the most important factor in the development of an effective helping relationship? So the most questions, all of these may be correct. Which one is the most compelling to develop an effective helping relationship? So the crux of social work, to have effective helping relationships. What's the most important factor of our answer choices? A, social workers training and experience in working with similar client populations. B, clients' willingness to view a social worker as a resource. C, nonverbal and verbal communication between a social worker and a client. Or D, agency policies that clearly articulate the roles of both a social worker and a client. All of these are important factors. Which one's the most important to build a helping relationship, and why? And why? So I see a lot of you putting answer choices. If you could put why you chose your selection, that'd be really helpful for the thought process as well. A lot of really good responses coming in. Okay, remember I said most questions, there could be factors that are important, but we're looking for the best one for a helping relationship. Social workers training and expertise in working with similar client populations. That could definitely be important, but there are many skilled people that would not be an appropriate fit or be the only reason that would give an effective helping relationship. Training and experience is helpful, but that doesn't mean you're going to be the right fit for that client, right? So I always tell people, don't take it personally if it's just not the right fit therapeutically. Like there are so many reasons. There could be past traumas. There could be just so many variety of things that cause someone to feel comfortable with a clinician or not. So A is not the most important factor. It's definitely, we have to be trained and we have to have experience. That would be going against the code of ethics if we did not do that. Agency policies that clearly articulate the roles of the social worker and a client. Every agency should have policies that dictate the roles of a social worker and a client. It's helpful. Is it the most important thing of developing a helping relationship? No. It's important, not the most important. Clients' willingness to view the social worker as a resource. Definitely helpful, but how are we going to get there? Got to build rapport. We got to engage. We've got to build trust. So it's important, but it's not the most important. C, nonverbal and verbal communication between a social worker and a client. Why is that so important? Why is that so important? I think it's so important because this spans all ages, all walks of life, right? You might be someone that does early childhood mental health. A lot of the work you're going to be doing with that client is nonverbal. They might not even have the words. You might be working with clients that have health conditions that make it impossible to verbally communicate. Nonverbal cues can give so much. What if you went into a session and the client had really poor body language and they seemed like they didn't want to be there? I do think you're going to really build an effective helping relationship. No. So I always tell people, make sure you're really mindful of not only your verbal communication, but your nonverbal, right? Does the client look at ease? Do you look at ease? Like there's so much power in nonverbal communication because it is communication. So it's really, really, really important. I think that's why social work and clinical settings can be so challenging. we're not only doing a lot of skills clinically, but we are reading the room. We are picking up on the cues of our client. I think that we have so much perception into what is going on, right? We can pick up when there's energies in the room, or when the client looks tense, or super important. Super important. I mean, how many times have you worked with someone, a client, or maybe in your work, or even a coworker, and you can tell they're having an off day? Their body language says it all, right? They're really tense. Maybe they're huffing and puffing. Maybe they're not making eye contact. Verbal and nonverbal communication goes so far, right? You need to build relationship skills, and that does not have to just be with talk therapy. It can be with a variety. It can just be sitting in silence and knowing that you are there as a support, right? It can be a variety of different things. So this is the best answer. Nonverbal and verbal communication are a must. Any questions on number 5? Okay. Number 6, let me make this bigger. Okay. Number 6, this one's kind of a lengthier question stem. So before we even go through answer choices A, B, C, and D, I do want to break this one down together. So don't put your answer choice in until we go through breaking it down. Number 6, a social worker has been facilitating a treatment group for 6 weeks. The group has entered the norming phase and has started to make clinical progress towards the established treatment goals. The social worker encounters a family emergency and will need to go out on leave under FMLA. What would be the most important consideration the social worker should make for the group members? What would be the most important consideration? Before you even answer, what's important here? There's a lot going on. This kind of tells us a story. What is going on here? What's our role? We are a group facilitator. Facilitating is a key word here. You need to know about groups. It's a treatment group and it's been running for 6 weeks. So this has been established. You need to know about group work. Group work is very different than any other type of work. What is going on? They're in the norming phase. Who in the chat, what does the norming phase mean? What does the norming phase mean? They've started to kind of catch their stride, right? Like things are starting to kind of gel. They're setting boundaries. They're starting to get comfortable with one another. It's stable. They're getting to know each other. It's a very important phase, the norming phase. We're trying to normalize what is going on in this group. We're filling each other out. Cohesion, developing rules, establishing norms. They're starting to make progress. So they're actually probably going from the norming to kind of that performing phase. So they're kind of moving in stride. Social worker has a family emergency and needs to go out on leave under FMLA. What does FMLA mean? What does that mean for our clients if people need to go out on it? This tells us a little bit of information too. Family Medical Leave Act, right? It's law. Sometimes you might need to go out on leave. It's offered by employers. Family emergency, need to go out. What would be the most important consideration the social worker should make for group members? So this group's been going, person's been facilitating, group leader needs to leave. This is life, right? Things happen. Emergency came up. What consideration does the social worker need to make and why? So go ahead, read your answer choices here. And why is that the most important consideration? The social worker should make an effort to ensure the group can have a consistent and competent facilitator in her absence. The social worker should prepare to terminate the group. C, the social worker should ask the group members if they would like the group to be self-led during her absence, or the social worker should provide referrals for an outside group with a permanent facilitator. What do we do and why? This does get into the code of ethics. I think some people are bringing up some really good things. A lot of really good ones here. So let's start eliminating. What would be wrong if the social worker was like, I'm going on leave, I need to terminate the group? B should be out. What is really problematic about B? B is problematic because this would be kind of erasing all of that progress and it could cause harm to the group, right? This would not be clinically appropriate at this time. It could cause harm, especially in a group setting where in a group setting, the facilitator is important, but the group process is more important than anything, right? The relationships made in the group, the progress that they're making is more important. So B, too abrupt, abandoning the client. What is problematic about C? That the group should be asked if they'd like to do it self-led until the social worker comes back. What's problematic about C? Power dynamics. Is it clinically appropriate for it to be self-led, right? We don't have any idea what they're in treatment for. We are the expert, right? That we cannot ensure that they are experts and that it would be appropriate at all. So C would be out too. We don't have enough information to determine that that would be appropriate. We don't know if they're competent. We don't know what's going on. The social worker should provide referrals to an outside group with a permanent facilitator. What's wrong with that? Here's referrals. I would like you to go to a group where there is someone that maybe can provide more stability. We're assuming they want to do that, right? They might be really enjoying the time with the other group members, right? We don't want to just assume that they want an outside group. They might, the purpose of groups is that oftentimes you're learning from the group members and they have a lot to add to the group as well. The outside group's unknown. We don't know if that's going to be appropriate for them. We don't have enough information to make that as a determination. Process of elimination. A, the social worker should make an effort to ensure the group can have a consistent and competent facilitator. It happens, the clients, you need to warn the clients if possible. So if you know you're going out on leave, like maybe you need to go out, you need to prep the clients, you need to process this with them, and you need to, if you do know that you will have someone filling in, or you'll be out for X amount of time, they need to know that, and they need to have stability. It could be really detrimental if all of a sudden you say this group that you've been coming to for 6 weeks is going to end because I can't be there, right? That could be really problematic. We need to make every effort to provide continuity of services. We need to do our best, knowing that this is life and some things we can't control, but we need to make every effort to do so. We need to make every effort to do so. A lot of agencies might, temporarily staff it or have someone else fill in or find some way. You have to protect the clients. And life happens, right? There are emergencies that come up. People need to go out on leave. It is part of life. So A is the most appropriate consideration. Any questions on number 6? Someone said, if you know you'll be out, should the new facilitator come in? If possible, it'd be great if you could do kind of a transition session, knowing that would be the best case scenario. But sometimes you might have to go out and you might have to say, I have to go out tomorrow. It's really a family emergency. So in a perfect world, yes, you'd have like a transition session. You get to make sure that the clients or the group members can meet that person in a perfect world, but knowing in some cases that might not be possible. But if you know who's going to take your place and you can introduce them, I think it would definitely be appropriate. Okay. Number 7. This is basically a recall question. You're going to get very few of these on the exam, but you need to know the details of it. So number 7, all of the following would be included in a mental status exam, except, so we're looking for what would not be included in a mental status exam. You need to know what a mental status exam is. You need to know what it entails. What would you not include? A, appearance of the client. B, cognitive functioning in present time. C, intellectual proficiency, or D, rate and rhythm of speech. What do you know about mental status exams? What would you not include? And why would you not include it? Why would you not include that in a mental status exam? I'll give you all a few moments to answer, and then we're going to talk about what is a mental status exam. Okay. What do we know about a mental status exam? What is it and why would we do it? What is a mental status exam? Why would we do it? We're trying to get information about if the client is oriented, right? Present functioning. We're trying to get a baseline of what's going on. Are they alert? What is their thinking like in that present time? So, appearance of the client, is that included in a mental status exam? Yes. And that is just, how did the client present? There might be some clients that present and they look very disheveled, right? That could be an important piece of information. So appearance could definitely be included in a mental status exam. Cognitive functioning in present time. This is really important in a mental status exam, right? What is their cognition like at this time? This is a moment in time. Definitely included. So that's not the correct answer. Intellectual proficiency. This is another word for IQ. Would we ever be able to determine IQ in a mental status exam? No, that is IQ testing. That is, we could make assumptions, but that's not appropriate for a mental status exam. You would need thorough testing, usually from some sort of psychologist or psychiatrist for intellectual proficiency, not included in a mental status exam. Rate and rhythm in speech definitely could be included in mental status exam. Is the client talking at a very rapid pace? Is the client kind of drawing out their words or slurring their speech? Intellectual proficiency, not mental status exam, not included. So this is just a recall. You need to know what is included in a mental status exam. Any questions on number 7? That one's straight to the point, right? We don't perform IQ testing. We don't perform IQ testing. Okay, number 8. We are almost to the end of our questions here. We've got 8, 9, and 10. Number 8, a social worker meets with a family who just lost one of their family members to suicide. The family is in crisis and is having difficulty coping with the loss. What should the social worker do to support this family? Very straightforward. What's going on here? We're meeting with a family. The family is our client. They're experiencing a loss. One of their family members was died to suicide. Keyword here, they are in crisis. Before we even start, what do we know about crisis? If you see that a client is in crisis, what does that kind of trigger for you in your brain? Crisis usually means immediate. A lot of people are saying stability, right? Stability is super important when a client's in crisis. There's some sort of dysfunction or disequilibrium. They're vulnerable. Clients are very vulnerable that are in crisis. Are clients in crisis usually at normal functioning? See a lot of people shaking their head no. So remember, when you're in crisis, your brain is working in crisis mode. It's not at normal functioning. So what should the social worker do to support this family that's in crisis? Refer the clients to family therapy. Assist the family in processing the loss to promote stability. Educate the family on the grief process and suggest coping mechanisms, or collect more information about the family history of mental illness. What would be most supportive and why at this time? What would be most supportive and why at this time? In crisis, experiencing a loss. You also need to know a little bit about the grief process here. Trauma might be something to think about here. Let's go through, let's start eliminating. Why would we not refer them at this point? They might need family therapy. Why would we not refer them at this point? Is that meeting the client where they're at? If we're like, you're in crisis, go to a family therapist. might be necessary down the road, but when they're in crisis, you're not just going to refer them out. That does not meet them where they're at. It doesn't stabilize them. They're in crisis. Collect more information about the family history of mental illness. Is this helpful at this point? They just lost their family member. Is this helpful? No, it's dismissive. It's inappropriate. It's ignoring the problem. And it's just not appropriate at this time. It's insensitive. They are grieving. So this is not supportive. This is not helpful at this point, right? You're not completing a family assessment and collecting more information. They're in crisis. What is wrong with C? Educating them on the grief process and suggesting coping mechanisms. What's wrong with that? We don't know if they need education. And when people are in crisis, is their brain functioning in the best way to take information in? Right? I always bring it back to like a child that's having a temper tantrum. They're on the floor, they're tantruming. Do you think if we are telling them coping strategies in that moment, they're going to be hearing what they have to say? No, because they're in crisis. Your brain is literally not functioning at a stabilized level at that point, right? You are fight or flight in that moment. So educating them on the grief process and suggesting coping mechanisms is not appropriate at this time. They need time to process. They need time to get the family unit out of crisis and to promote stability. So B is the correct answer. We meet them where they're at, right? And they might process it in different ways than we would, right? We meet them where they're at, and everyone processes and goes through the grieving process differently. So we need to show support. We need to give them the space to process, and we need to promote stability to get them to a place where they're not in crisis. Does that make sense? Okay. Okay. Number 9. I would say this is a combo between a recall question and an application question. So you got to kind of know what's going on, but you also need to apply it to the situation. So number 9, a group of social work colleagues come together once per month to discuss difficult cases in a supportive and confidential setting. Which of the following best describes this professional activity? So a group of colleagues are coming together once per month to discuss difficult cases. What do we call this? Clinical supervision, peer consultation, professional development, or multidisciplinary team meeting? What is the answer and why? Colleagues coming together to discuss confidential information once per month. This one sometimes trips people up. So let's start eliminating. Is this clinical supervision? What would make this not clinical supervision? It's not clinical supervision. Why not? Not specifically clinical supervision. Why not? There's nothing that suggests that there is someone supervising another person, right? So you might be talking about clinical things, but given the clues that we have, the definition, it's not clinical supervision. There's no one here that is assigned as a clinical supervisor. Is this professional development? Could be, but is that the best answer choice? No, right? It's not that you are going there to learn expertise in a certain area. Not the best answer. So I'll just eliminate that. Is this a multidisciplinary team meeting? Why or why not? We don't have enough information to know that we are meeting with other disciplines, right? We have here that we are social work colleagues. So it's not a multidisciplinary team meeting at this point. They might be having different client populations. We don't even know who these people are serving. There's not enough information. That is out. Peer consultation is the correct answer. Peer consultation is actually something that when people are fully licensed, it's very common. It's often to provide connections to talk about difficult cases, because think of if you're in private practice, you might be very isolated and you might, who do you go to talk to? So peer consultation is like really, really good. If you have a space where you need to talk about difficult situations, it is confidential. It's similar to clinical supervision. You process things, but it's with a group of peers. So you might be talking about your peer group or your group of clients, a peer might have their turn, and you kind of just brainstorm and talk about best practices, things that have worked or not worked. It is a group of colleagues coming together, putting their brains together. It's meant to really kind of be a reflection space. Sometimes you might do a peer consultation group to kind of just work on self-care, right? Like maybe you're all going to talk about how you were battling burnout, right? There could be so many reasons why you would get together with a group of colleagues, but this is peer consultation. Very, very common with fully licensed independent practitioners. It's not a place where you go and gossip, right? There has to be purpose to your group and it has to be productive. So that is peer consultation. Very, very great thing if you are able to be part of a peer consult group. Okay, last question tonight. Number 10. You are working in a pediatric hospital unit. One of the patients, a 7-year-old boy, has been admitted, but has not had any visitors. The child mentions that he feels sad that no one has come to see him. What should the social worker do first? Remember first questions. A lot of people say, well, what do I do with first questions? You need to put these in order. Where is our starting point? You're in a hospital. Client is 7. We don't know why he's in the hospital, but he's been admitted and he has no visitors. He says that he's lonely, or no, he's sad that no one has come to see him. What does the social worker do first? We're in a hospital. We have a patient, 7, no one's come to see him. He says he's sad. What should we do first and why? He's sad that his visitors have not come. What do we do and why? What do we do first and why? A lot of really good things here. So let's start eliminating. Do we have information here that medical neglect is occurring? No, the child's in the hospital. If anything, he's going to be getting the care he needs in the hospital. We don't know why he was admitted. That would be assumptions. We don't have any information that we would be able to report medical neglect. Also, not visiting your child in the hospital is not medical neglect, right? We have to take our personal feelings out of it. We might say that's awful that parents wouldn't go. That's an assumption. We have no idea why he's not getting visitors. Report the information to the attending physician. We might do that, right? We'd want to be talking to the team. We would want them to know what's going on, but would that be the first step, is to just go right to the doctor? We're the social worker. We're the ones that have expertise in dealing with these type of things. The physician would probably refer it back to you anyway, right? The physician is there for medical stuff, for medical decisions. So B is out. Arrange a schedule so an adult can sit with a child until a guardian arrives. That seems like a fair answer, right? But would that be the first thing that we do? And this doesn't give us enough information. Like hospitals right now are really, I don't know where you could arrange for an adult to sit with a child until a guardian arrives. Like you might have an advocate that could do that, but is that our very first step? Not at this time, right? You have to be realistic, right? So not at this time, C is not our first step. D, contact the family to inform them of the statement and collect more information. Why is this the best answer? This is what we should do first, but why is this the best answer? We need to know why they're not coming, right? Like we don't know if they even know, we don't have any indication. Maybe they have to work and they cannot come to see the child, right? Maybe they're on their way to come and see them after work hours, right? We don't have enough information. Maybe they don't have transportation to get to see the child. There are also like some cultural barriers here. Maybe in some cultures, they do not go see the child when they are in a hospital setting. I've actually worked with some people that, or maybe they have their own stuff that it's too hard for them to go into the hospital, right? Maybe they're not, there could be so many variety of different things, right? Maybe this child's in a specialty hospital that they have to travel a far distance, right? They might be sick themselves and they don't want to contract something. It's a hospital. There could be so many things. They need to be notified that the child said this. So what would you do if this was the correct answer we know is contact the family. Say you had this happen, you're in the hospital, the client says, I'm sad, no one's come to see me. What would you do? How would you approach the family? We don't want to place judgment, right? I know a lot of us would say, well, if I had a child, I'd be there with them every moment. That would be putting our own beliefs onto them. We'd want to give an update, right? Do they know this child's even been admitted? Do they have to just go in an ambulance? Like we don't have enough information. We don't have any idea why they aren't there yet, right? We don't know who is a guard, like, maybe there's some reason why the family cannot come. Someone said maybe they were at school and taken to the hospital, right? So does this family even know that the child has been admitted? Is he allowed visitors? What is a child like? This is also a 7-year-old. So what does he think visitors are? His friends coming? Like there could be so many different things that could be going on. You need to think of what's developmentally appropriate. There could be so many variety of different things. There are some cases where family can't be there. They have to go to work. They have to maybe be home to take care of a sick family member. That takes away their time. Maybe they themselves are sick or cannot be there. Any questions about that one? That one was a little bit trickier. Right. Someone said they might not have childcare. Absolutely. You might not want to drag 3 other kids to the house. That's not even a safe option right now, right? So there could be a variety of different things going on. Knowing that, we might be able to get an advocate to come. Like there's systems in the hospital where someone might be able to come visit with the child within the hospital, but first we need to collect more information. Any questions about that? I'm going to one more time share that study plan that we talked about. This is a sample study plan from someone that just recently passed, I believe last week. I'm sharing it in the chat. I will also share it as well. It's very important. Why I love this is this was very organized. You should do this if you have not yet, because it gives you a structure to work from. It knows that on Monday when I sit down, I'm doing mandated reporter, and the following Monday I'm doing unit 1. Someone said, why is that with this question, we can assume family are available to contact, but other questions it's not mentioned. If it's not mentioned, we can't assume. That we don't ever want to make assumptions. This is just the best answer given the answer choices that we have, because it's a minor. We have to contact someone. It could be the family, it could be a guardian. We have to contact someone. We can't not contact anyone because the child's 7. So that's what makes this one different. You have to remember this is a minor. Someone needs to make decisions for the child. Might not be a parent, it could be a guardian, but here someone needs to be contacted. Versus in the other ones, you wouldn't, because that'd be breaking confidentiality potentially if they are an adult. Does that make sense? Always different with minors. Any other questions? Okay. If you are, I will set our February study group dates by the end of the week. That will be on the platform. Remember, this will be recorded. Please keep coming to the study sessions, and please, I'm telling you, you're gonna be really successful if you have the opportunity to go through all of the modules as they're listed. There's a reason why they are in the order that it is. And if you can go through it twice, second time through, you're gonna be able to kind of pick with a, a fine tooth, get those details that you didn't the first time. So make sure that you set up yourself for success, and you have to follow the program through. A lot of people say, well, I didn't have time to finish it. Like, make sure you set the time aside so that you are prepared on test day. Any questions? Keep working through questions. Notice today you might not have gotten them all right. That doesn't matter. Did you pick apart important things? Were you able to eliminate? Were you able to assess who our client was, what the presenting problem was? Use those 5 W's. If you have any questions, you know where to email me. This will be available on the study platform a little bit later tonight. You'll also get it by email, and I hope to see you all in February for our next study sessions. Next, someone said they have a question about number 5. Go ahead. What is the question that you have? Someone did earlier, I didn't get a chance to get to this. They said, should we be thinking of the helping process for number 5? You should always be thinking of the helping process, right? Where are you with the client? Are you engaging with the client? Are you assessing the client? Where are you at? You should always be thinking of the helping process. Very, very, very helpful. The session dates and times are always posted on the study platform. So when you log on and you're going through the modules, it's the last one. It's called live study groups and past study groups. I also send an email with the dates as well. Any questions about anything? Okay, thank you very much. I will hopefully see everyone next month. And if you are testing soon, good luck. Please keep us updated. We're sending you good vibes. And let me know if you have any questions. Thanks, everyone.